To get started here, Dr. Kapoor's group has been very interested in the effects of unloading on infarct size reduction. And as you can see, we and several other groups here in this audience have shown that mechanical unloading prior to reperfusion results in infarct size reduction. And that's regardless of the method of mechanical unloading, whether it's tandem heart with LA femoral bypass or a transvalvular device like the Impella, you still see this relationship. So we're all particularly interested in the mechanisms that underlie this. The first mechanism of which is that a reduction in LV stroke work lowers myocardial oxygen demand by decreasing pressure volume area. I know Dr. Burkhoff has shown a lot of this data already, and so when you activate the Impella CP, you can look at the pressure volume loop on the bottom, and you see there's a nice unloading effect shifting down and to the left, indicating a reduction in mechanical work and myocardial oxygen consumption. Another mechanism that underlies this that we think is that of functional perfusion to the area at risk. And what that is where activation of a transvalvular pump increases myocardial perfusion to an ischemic territory despite persistent coronary occlusion. And this isn't a new theory. This dates back as far as at least 1989 with Smalling and Wampler using the hemopump, where in a canine model they showed with LAD occlusion and activation of the hemopump, there is increased perfusion to the ischemic zone as measured by microspheres. And so in theory, this is due to improvement in microcirculatory collateral flow. And a gold standard of measuring this is the collateral flow index. And as you can see here, the collateral flow index is the coronary wedge pressure distal to an occlusion, normalized to the right atrial pressure, divided by the aortic root pressure, normalized to the right atrial pressure. And the CFI itself has been shown many times to be independently correlated with extent of myocardial ischemia. So this led to our hypothesis, which is that compared to primary reperfusion, primary unloading recruits collateral microcirculatory flow, increasing functional perfusion to an ischemic zone and reducing infarct size. So in this diagram here, I'm going to show you kind of what we were looking at. So again, this is aortic root pressure, coronary wedge pressure, right atrial pressure. In theory, these are epicardial coronary vessels. This is an occlusion, and this is the area at risk. So the CFI equation is calculated here, and in theory, this is the black is the infarct. So with primary reperfusion, you improve blood flow immediately to the area, and then you have your infarct. You're perfusing through a necrotic core. There's oxidative stress, mitochondrial dysfunction. So what happens when you have an Impella in place or you unload prior to reperfusion? So you activate the Impella, the occlusion stays there. So in theory, we think that coronary wedge pressure is going to increase, which is going to increase your CFI and potentially decrease your infarct size. So to study this, we used a swine model of 4 to 6 swine per group and then separating into 3 separate groups. And so there was a primary reperfusion arm, we had an Impella arm, and a VA ECMO arm. All of them underwent 90 minutes of LAD occlusion to start, and then from there, the 3 groups started to separate. So the primary reperfusion group had 30 more minutes of LAD occlusion, followed by reperfusion. The Impella arm had 30 minutes of continued LAD occlusion, but with activation of an Impella CP at P8, followed by reperfusion. And the ECMO arm had 30 minutes of LAD occlusion with activation of ECMO at 7,500 RPM, followed by reperfusion. And throughout this whole time, we have conductance catheters in, we're measuring pressure volume loops, we have a PA catheter in, we're looking at CFI, and at the end of this all, we euthanize, harvest the hearts, and suction them with TTC staining to look at infarct size. So I'm going to take you through the results of what we found. So to start, and this has already been shown in one of the earlier talks, so what was the effect on infarct size? These are some representative images here where everything that's blue is not the area at risk, red is viable myocardium, and white is infarcted tissue. So looking at infarct size across Impella, Control, and VA ECMO, we saw that, as previously shown, Impella reduces infarct size relative to the two. There was not a statistical difference, however, between Control and VA ECMO. So what happens with the CFI and how long does it take to actually alter the CFI? And so what I have here, or we have here, is the delta change in CFI and as well as the fold change from CFI from relative baseline, which is just prior to pump activation. So that key 90 to 120 minute mark of LAD occlusion, what's going on with the CFI there? And again, so in blue is control, red is Impella, and green is VA ECMO. And we see that you activate whatever pump is in the specific arm, and within 30 minutes, we see a rise in the CFI. And we don't, however, see really a change in the CFI associated with VA ECMO. So what we're saying is that within 30 minutes of LV unloading, we see microcirculatory flow increase to the area at risk. And I'm going to show actually what we're looking at with the hemodynamic tracings themselves. So this is, again, control, Impella, VA ECMO. And the blue tracings across all of these are the aortic root pressure tracing, and the red tracing across all of these is the distal coronary wedge pressure tracing. So they're equal throughout at the beginning, and then during early LAD occlusion with no activation of pump, they separate out. And then interestingly, you can see here with Impella, there's a rise in the coronary wedge pressure, systolic and mean pressure here. And there's also, you lose some pulsatility in the aortic root pressure tracing. Versus with VA ECMO, you actually see no real change here in the coronary wedge pressure tracing, but you do drive up aortic root pressures. So that's a little bit of an inclination as to why we're seeing that change in the CFI itself. And so does that workload change really correlate with microcirculatory perfusion? What we first did was we took a look at all the LV stroke work changes between 90 minutes and 120 minutes. So when the animals were either getting continued LAD occlusion, Impella activation, or VA ECMO. And we see that Impella reduces LV stroke work over that period of time. However, we don't see a change with control, we don't see a change with VA ECMO. And when you take that stroke work and you plot it against the CFI to see if there's a relationship between a reduction in stroke work and an increase in CFI, we do see that that trend is there, and that's statistically significant. So on this y-axis, we have the change in stroke work between 90 and 120 minutes, and on the x-axis, we have the change in CFI over that period of time. LV stroke work ultimately correlated inversely with the change in CFI, and you can kind of see the control and the VA ECMO groups are bunched together out here, and more of our Impella animals are coming down into this quadrant here, meaning increase in microcirculatory flow. And then when we actually dive a little further and look into the individual components of the CFI, we did the same regression plot, but we looked at the individual coronary wedge systolic pressure, coronary wedge diastolic pressure, mean pressure, and we see that there's a definite trend towards a relationship between that change in stroke work as well as an increase in the wedge systolic pressure. And there's an actual significant correlation between the change in stroke work and the change in pulse pressure here. So systolic minus diastolic pressure at the coronary wedge. And again, you have your VA ECMO and control arms kind of bunched over into the upper left quadrant, and your Impella arms are bunched down into the bottom right quadrant. So ultimately, we said that LV stroke work correlates inversely with an increasing coronary wedge pulse pressure. So when we put this all together and we try to connect from LV load, microcirculatory flow, infarct size, I already showed you this figure here when we started, which is our infarct sizes across the groups. We plotted and wanted to see whether there was a relationship between that CFI and the infarct size. And you can see that a rising CFI over that time period of 90 to 120 minutes correlated inversely with a reduction in infarct. It was, again, an even stronger correlation when we look specifically at that pulse pressure rise, which was the biggest change in the Impella group. We said that reducing LV load and increasing the CFI and coronary wedge pulse pressure is associated with a smaller myocardial infarct size. So in conclusion, this is the first study to show that reducing LV stroke work with Impella prior to coronary perfusion increases collateral flow to the infarct-related artery in AMI. And VA ECMO is similar to control in that it does not augment collateral flow, and we saw similar infarct size as control. And all put together, these findings support that ventricular unloading promotes functional perfusion to an area at risk. And so a better understanding of how these devices work and affect in myocardial perfusion is going to ultimately impact, clinical trial design and clinical outcomes. And there's a balance here where, VA ECMO, we're seeing increased MAP, but not really a change in stroke work or change in CFI. And with transvalvular unloading with the Impella, we see a rising MAP, but reduced stroke work and improved CFI, which, we're going to investigate further with the DTU STEMI clinical trial. So, thank you.
Any question?
Q?
Yeah, Q.
The CFI equation, the top part is
subtraction of the wedge pressure minus right atrial pressure. And when you turn on Impella, you run load the RA, and ECMO does it reverse. So I wondered if you superimpose the wedge pressure to RA and see the pressure difference at different time points. Mm-hmm. You may also get some insight in when it's flowing.
Yeah, that's an interesting comment. And when we looked at specifically the changes in RA pressure over the same time period as well, and like you alluded to, there is a reduction in RA pressure when activation of VA ECMO without an abrupt change, and there was no change in RA pressure with Impella. So that'd be interesting to plot them at individual time points and try to see if there's any other significance there.
Jeff?
As an interventional cardiologist, I'm used to thinking of wedge pressure as an index of IMR and distal flow. So can you walk me through the phasic aspect? Because I'm trying to understand the systolic. I'm trying to understand what the systolic rise means, and how that occurs, and how the collateral flow increases the systolic pressure.
You're asking what is happening with the phasics in the distal bed?
Why does it rise in systole?
So
I'm trying to envision that.
Yeah, we tried to answer this question ourselves. We had volcano wires in the epicardial cord, the collateral epicardial coronary vessels. So this is LED. We were looking at left circumflex coronary flow, and interestingly, across all three groups, we didn't see a velocity flow change associated with activation of these devices. So, it makes you think that there's some connection between unloading and recruitment of existing vasculature flow in the microvascular bed that's accounting for that.
The pigs are not supposed to have collateral circulation, basically. So do you think that tissue edema, unloading may affect tissue edema and thereby have a positive effect on CFI?
Yeah, that's certainly possible. I think then the next step is try to make that connection between what's happening with the unloading and edema within the infarct.
Very good. One final question here, and then I have a couple of announcements.
Real briefly, do you have any data on coronary flow? Because I think on one of your slides you showed the MAP went down with Impella support, but getting to his question about why did the distal pressures go up? Mm-hmm. So do you have the coronary flow increase with one but not the other?
We weren't measuring coronary flow velocity in the LAD territory. We were measuring coronary flow velocity in the collateral vessels.
Okay, right. So I'm trying to figure out, to his question, why that went up.
Yeah.
If your MAP went down. Was it because of the edema? Is it because of increased coronary flow? Yeah. What am I missing as a surgeon who doesn't do this kind of stuff every day?
So maybe I'll jump in on that one. We did a number of things. So Devaka Pereira is here. He's one of world leaders in coronary flow and autoregulation. And the way we did this study, actually, the original intent was to look at coronary wave energetics. And so we looked at the LAD flow and we looked at the circumflex flow, the area at risk and the non-area at risk, to get a sense of collaterals. We were anticipating, again, that we would see an increase in the flow velocity in the circumflex, and we'd have a very nice, simple explanation, and then we would be able to see that affect the LAD territory flow. But we didn't see that. And in fact, we did initially try to measure flow in an occluded LAD to see if the flow is going up because of collateral flow through the circ. And we basically didn't see a significant change just in the flow velocity. It's very difficult to measure with the LAD occluded. So what we're realizing is that if it's not increased flow velocity through the circumflex, if it's not, and we see a very consistent effect on this increase in the wedge pressure. In fact, as you saw, that was the tightest correlation that we were finding. The question is, where else could it be coming from? And this actually takes us all the way back to, we started engaging the literature in Gleb and Rep. So Shiv got to get a little history lesson back to the 1800s. But some of this idea of coronary ventricular coupling and autoregulation. So in the circ territory, it's a non-ischemic territory. In the LAD territory, it's ischemic. So you assume that autoregulation is uncoupled. And so if autoregulation is uncoupled, that may explain why, just by unloading itself, you actually start to slowly recruit through various microcirculatory mechanisms flow into that area at risk without getting a change in epicardial flow velocity. And so we think actually the data is suggesting that direct effect of unloading on microcirculatory flow, independent of your epicardial mean arterial pressure. And the ECMO arm was designed to push that further by increasing mean arterial pressure. We expected APV, or flow velocity, in the circ to go up, and we thought the exact opposite finding. We would see more wedge pressure in the distal LAD territory, and we didn't see that. And most likely that's because the autoregulation's intact in the circ, so the microcirculatory vessels would clamp down, and you won't see a change in the flow velocity, and you didn't see a change in the wedge. So a lot of things happening at the same time, but this was one of the first investigations of this collateral flow index and the link between unloading and CFI, which is what Wampler had shown, 3 decades ago, using a different type of technique.
Dan, final question for the morning.
I think, obviously this is, a new frontier and really critical, which is, I think, why this abstract received the Young Investigators Award. So it's really critical. And in your index, the collateral flow index, you use the right atrial pressure as the downstream pressure. So there's always a lot of debate whether it's right atrial pressure, in the coronary sinus, or is it left ventricular and diastolic pressure. So the way I think about this is also that there may be a difference between the subendocardium and the epicardial layers. And I think there probably is a room or a role to go back and using microsphere technology to quantify and understand the differential hemodynamic effects of LVEDP and RAP. So it's just a comment. And maybe, do you have any thoughts about CVP versus LVEDP as the downstream pressure for coronary perfusion?
That's an interesting comment and something we discussed. I think it really just means we got to, look at the differences in the relationship with using LVEDP versus RA pressure. We haven't actually examined that.
Because that's clearly one potential difference between Impella and ECMO.
ECMO, yeah.
And also that may also link with differences in the pulsatility, which I also don't understand exactly the role, but it's, it's the first time I saw this data. It's really cool. But that pulsatility clearly relates to not only flow, but the resistance, time-varying resistance due to mechanical contraction above and beyond autoregulation.
So this just shows us that in the opening session of the third ACURE, we are going almost 45 minutes behind the time because there is such an amazing discussion on flow, on metabolic, on exons, and the amount of research and study. Now the science behind unloading is just bursting out of here. So
thank you.